So welcome, everyone. Let's give yourselves a round of applause for being here. So I'd like to welcome everyone to the AMA Healthcare Interoperability and Innovation Challenge Pitch-Off event. And first, my name's Jim Ryan. I'm the co-founder and COO of Medstro. I'm really excited that the AMA has invested in the medical innovation community and has been leading this challenge. And the challenge ran online, and it's culminated in this live event that we've had for you here tonight. I'd also like to thank Google Cloud for sponsoring the challenge. You're about to watch 8 finalist teams pitch off against each other, similar to Shark Tank. The first place winner will take home a prize of $25,000 in Google Cloud credits, sponsored by Google Cloud. The second place winner will take home $15,000, and the third place winner will get $10,000 Google Cloud credits. So these prizes up for grabs today. But you might ask yourself, how did we determine which teams are here presenting today? And actually, that was a process, an online process that took place all the way for the last few months. We know, everybody I hope agrees that innovation in healthcare does not happen in a vacuum, and it doesn't happen in a silo. It requires open dialogue, it requires a collaborative process and building communities. And for that reason, the AMA launched the AMA Healthcare Interoperability and Innovation Challenge, first on an online platform and then here tonight. For 3 months, entrepreneurs from all over the world submitted their ideas to the online challenge about how to best use patient-generated health data to improve physician workflow, improve clinical outcomes, or reduce cost, or preferably all three, in the healthcare system. We got a total of 38 submissions from as far away as Australia, and we had a crowd voting period during which we invited everybody to read through the submissions and vote for their favorites. We had nearly 2,000 votes from over 50 countries around the world, so very, very popular. And as a result, we've picked these 8 teams who are coming up here tonight. They've made it to the final round. They will be presenting. The judges will be asking them questions, and we'll see who the winners are. But before that, I would like to welcome our keynote speaker, Dr. Michael Hodgkins, the Vice President and Chief Medical Innovation Officer of the AMA. Dr. Hodgkins.
Thanks, Jim. Chief Medical Information Officer. I wish I could be the Chief Medical Innovation Officer. That sounds much better. I'd like to add my welcome to you, our guests, and especially to our finalists and judges. Thank you very much. And to our sponsor, Google Cloud. Let me start by asking some questions of the audience. How many physicians in the audience? Show of hands. Down. How many nurses in the audience? How many other healthcare professionals in the audience? Oh, a lot. Anybody want to say what kind of healthcare professional you are, since I didn't get you with MD or nurse? Just speak up. Clinical assistant. Okay, informaticists in the audience? You don't have to have a degree in informatics to say you're an informaticist. Come on. Okay, we'll keep the secret between us. How about just engineering backgrounds? Yeah? Okay, good. Very good group. The importance of this challenge, I think, can't be overstated. The importance of the ability to exchange information at a distance between patients and their care team is the key to the future of healthcare. In an age of chronic disease, the idea that we can succeed in the management of chronic disease in the 4 walls of a clinic is an idea that we need to get beyond. And the example that I use most often is hypertension. We've got a lot of patients with hypertension in the United States, but guess what? How many do you think we successfully manage on average? Anybody want to offer a guess? Speak up. 25%. Anybody else? 5%. Oh, you're a real skeptic. Well, we do a little better than that. We do 50%. But I think we have to do better than a coin flip. And the emerging trend in the management of hypertension is to rely on self-measured blood pressure. The belief is that that's the most accurate way to manage hypertension, even to diagnose hypertension. It hasn't quite become the standard of care, but I think it's rapidly approaching the standard of care. And if we're going to measure blood pressure at a distance, if we're going to have people measure it in their homes, we have to make sure that the conditions for accurate measurement are being met. And there are many conditions that can affect the accuracy of your blood pressure, not just the device that you're using, just the position that you're in. If you're not seated and comfortable with your feet on the ground, and if you haven't been at rest for at least a 5-minute period, guess what? You won't get an accurate measurement. And there are other conditions that I won't mention because it's a mixed crowd and we don't want to go there. So, but you've got to be able to then exchange that information in a way that is useful. And it's not enough to be able to rely on the accuracy of the measurement and the security of the measurement in transit. You also have to have meaningful data that both patients and physicians can act upon. And this effort, this initiative, or this challenge has grown out of an initiative at the AMA called the Integrated Health Model Initiative, which is something that we launched this past October. So it's really very early stage. And I want to describe that effort to you in a little more detail. It starts with the notion that data is the problem. Now, you might say data is the solution, but not all data is created equally, and not all data is equally valuable. And we have certain standards for the exchange of data between electronic health records, but even that isn't the best solution that we have right now. And in many cases, it's not machine readable. So if you exchange information between disparate electronic health record systems, even though you're using a common format, as often as not, it's going to be dropped to paper because the machine on the other end can't consume it. So that's a problem already. But then when you add to that the fact that we're going to be using devices at home and applications at home and what have you, the problems become exponentially more difficult because as much as we've tried to standardize the exchange of information between electronic health records, we haven't even begun to standardize how information between these devices and applications that are going to be used at home, how that data is standardized in a way that people can rely on it. And the other thing is that it's sort of a little secret among the clinical professionals in the room, but only about 30% of the work that we do really contributes to success in the treatment of chronic disease. Much of the rest, once you get beyond genomes and biomes and what have you, it really is reflected in the patient's behavior, and their behavior, we know, is affected by their environment. And I don't mean, whether they live next to a polluted lake, although that could be a factor. I mean, do they have housing? Do they have easy access to fresh foods and the like? Do they have easy access to their care, to their prescriptions, and so forth? Can they even afford their prescriptions? So these so-called social determinants of health and other factors, that's information that we really don't even collect today. And we certainly don't even have a standard way of collecting it. And the Integrated Health Model Initiative is focused on how we do that better. The initiative is a market-facing initiative that has 3 components. It has an online collaborative platform community that anybody can go to. You can go to the website today and easily register and participate. And the community is made up of clinical folks, of engineering and informatics folks, and they're there to have dialogue about how to best achieve a common language that we can all rely on and that will be machine readable so that when we're exchanging this information, it's really going to work for us as physicians. So they're informing the development of this common data model, as it's referred to here. And but as that information is exchanged amongst and between the collaborative community and the AMA, we're also running it through what we're calling a clinical validation process. And this is sort of the 80-20 rule. We want to make sure that there's enough evidence to support the use of the data that will go into the model. But ultimately, the test of the model is its success in the marketplace. And there are a number of feedback loops, most importantly from those that are actually using it in software in the market, to tell us what works in the model and what doesn't work in the model. This is a very high-level view of what the model looks like. And it starts at the bottom with a coding layer. And the thing that I want to emphasize, because I'm sure that the informatics folks in the audience are going to have this question. They're going to say, what about SNOMED? What about CBT? What about ICD? What about, whatever language you choose? And what I wanted to emphasize is that we're not starting from scratch. We're incorporating in the coding layer any existing nomenclature that has concepts that are worth including. But for those of you familiar with those nomenclatures, you know that there's also ambiguity both within and across nomenclatures. So we're trying to rationalize that. And then we're trying to fill in, for lack of a better term, the gaps, but the gaps probably are going to account for the majority of the information, to deal with these social determinants of health, to deal with functional status of the patient, to deal with patient goals. If you're treating a patient with hypertension, a common patient goal is, I hope I can take this medication without side effects, because I've got hypertension, but it doesn't really affect me day to day. I don't have any experience of the fact that I have hypertension, but I sure would like to avoid the downstream problems associated with uncontrolled hypertension. In the meantime, can we do this in a way that doesn't interfere with my life? So that's a patient goal. That's not always a physician goal. The physician wants to control the blood pressure, but many times they'll ask about side effects. But I think it's equally important to hear from the patient what their goals of treatment are. So from the coding layer, we come up to what we call the context layer, where we're assembling concepts into more complex arrays to address specific use cases. And then ultimately, at the knowledge layer, we're bringing together a lot of these concepts and constructs in a way that can be deployed in software through these devices and the applications that we're talking about that will be useful in managing chronic diseases at a distance. A little bit more information about the model. So it's not just a model. If I gave you a module from the Integrated Health Model Initiative, you wouldn't know what to do with it. If you're a software developer or someone else interested in using the model, you need more than that. So we have the blueprint, and the examples that are included with that are use cases, specific clinical examples about what that module is intended for and so forth. We have the module itself, and then we have a developer toolkit. All of that's part of what we release along with the content module, so that you actually can figure out how best to deploy it in your software. And but going back to the example of hypertension, this is a fairly simplistic flow chart to look at what we're in the process of doing now to actually demonstrate the success of the model in producing accurate results. So it starts with the patient at home, could be at work, measuring their blood pressure using a home monitoring device. Typically that device will talk to an application on their smartphone. That information has to go somewhere, and I think largely it's going to wind up in the cloud. I don't really see it being transmitted directly to an electronic health record. It needs to be processed in some way. There needs to be some intelligence applied to it, because the last thing the clinical team wants is thousands of measurements. It's like, what do I do with that information? What they want is something that's digestible and actionable, and the same is true for the patient. Ultimately, we do recognize the need to make this information available in the electronic health record, which is, for better or worse, the way in which we manage care today. That'll change over time, but for today, we have to make sure that there's a place for it in the record and that it can get there without anybody having to touch it. No manual interventions. This has to all be machine readable. And then ultimately, it has to drive effective decisions, both by the patient and their clinical team, to improve their care. Why the AMA? Well, we like to think of ourselves as successful in convening members of the healthcare community broadly to various ends. And in this case, we think that we can perform in this role. But as I said, there's nothing proprietary about this. The reason we set up a platform was we want to engage the community, we want to engage the marketplace, we want to engage the developers, the industry, and so forth. And we're relying on them to tell us whether the model's working for them or not so that we can refine it over time. This is not a one and done. This is going to be a long-term process that the AMA is committed to and invested in, and very consistent with our mission to promote the art and science of medicine and the betterment of the public health. We represent the interests of a large number of physicians, not all physicians, I'm sure. Some of you in the room are AMA members, some of you are not, doesn't matter. You can still participate in the Integrated Health Model Initiative. But we think that we are an honest broker for this, and our various collaborators and partners, have told us that that's important to them, that we can serve in that role, as opposed to a commercial entity trying to perform in that role. So the last slide I'll show you are just a smattering of some of the partners that we already have involved in this initiative, and we're working very actively with them to evaluate the code sets that we're going to produce and to be able to demonstrate their effectiveness in the real world. So I'll stop there, and I think it's time to turn things over to our finalists and judges. So thank you very much.
Thank you, Dr. Hodgkins. So, where are we? Next, we'll get into our finalist presentations. But before that, I'd like to introduce our judges. And I'm going to introduce all of them at once, so please hold your applause to the end. And I don't think you're seated in the order that I have you written down. But I'll just read out the names, and then you can give them a round of applause. So first, we have Dr. Stephen Stack, former president of the American Medical Association. We have Dr. Mahek Shah, the senior project leader and senior researcher at Harvard Business School. Dr. Floyd Eisenberg, president of iParsimony LLC. Robin Glasgow, chief innovation officer, Blue Cross Blue Shield, Massachusetts. Dr. Joe Corkery, head of product at Google Cloud. And Dr. William Kassler, Deputy Chief Health Officer and Lead Population Health Officer at IBM Watson Health. So thank you to all of our judges for being here and helping make this successful. Okay. Wait, I probably should have shown you that earlier, but maybe that would have ruined the surprise. Okay. So first, the first team to present tonight, please welcome to the stage Carium.
All right, good evening, everybody. Thank you to the AMA and Google for hosting this wonderful event tonight and for giving us the opportunity to present our solution and our proposal to the call for submissions around interoperability and innovation in healthcare. So, we launched Carium on April 9th of 2018, and that is the same day that the AMA launched this interoperability challenge. And I can't tell you that our office looked much different from what's on the screen here. And let me tell you a little bit about why. So when we launched Carium, we really wanted to do something that was very individual focused, where we've seen the trends in the industry, we've seen the potential tsunami that's coming with data and the use of data, and we couldn't have seen a better alignment with what we were doing relative to what was in the call. And so, if we look at kind of the collision course we're on, there is this massive tsunami of data that is coming towards physicians and care teams, and the current systems are just not equipped to deal with that data. Beyond that, there is also this whole paradigm of an empowered consumer and an empowered patient that wants a digital platform to engage in their healthcare in a manner that is very different from the very episodic and discrete approach that's predominantly in use today. And what we fundamentally believe, and we're seeing it with the call for submissions here, is that the right technologies applied in the right way can help mitigate this potential mismatch and impedance between what patients want and what providers are able to offer, and ultimately what providers really want, which is a healthy, continual, strong, engaged relationship with their patient community, which ultimately drives better outcomes and lowers costs. So the core part of our solution is related to the data sharing that is so critical in what medicine is going to look like in the future, as we just heard. And so one of the key pieces of our technology is a personal health record system that allows for a comprehensive longitudinal patient health record that is also version controlled. And we're actually, in the interests of really expanding the use and really helping move medicine forward, we're actually exploring open sourcing this technology as well. And part of this technology is to allow multiple stakeholders to share in a health record, contribute to it, add to it, exchange it, give the patient the ability to add their own data to it, and also then let the physician and care team access patient-generated health data, social data, like how am I feeling, or how are my allergies today, or pictures of food, or whatever it may be, to ultimately get that data flowing back and forth. Having said that, one of the key elements that is really important from our perspective, and what was mentioned earlier as well, is data alone is not that interesting. Getting the data flow is the first step, but what's really going to be important is to be able to generate actionable insights and meaningful guidance toward both the individual as well as the care team and the physician from that data. And to that end, our submission includes a set of analytics engines that can process that data both in the context of an individual to provide them very specific coaching, as well as for the care team and the clinical team to understand what's really going on with them at a very individual basis, which is enabled today by patient-generated health data, wearables, and even the genome and other omes, and drive those insights, which are ultimately what's actionable. And those insights can be leveraged in a medium that is far richer than the traditional interfaces of the EMRs that are available today. And obviously, as mentioned earlier, there's no question that once these insights are derived, critical data points need to get pushed back into the EMR for use in clinic and at the point of care. But the care team has the opportunity to use much richer interfaces, timeline views that show the patient journey, show how they're feeling, the social determinants, their prescriptions, and all of that data in a much more intuitive interface. And so what that results in is a patient and a provider working together off the same set of data, sharing in the care plan, and together really embracing the journey, and resulting ultimately in better engagement, a better patient-provider relationship, better outcomes, and driving lower costs. And so with that, I'd like to thank you for the opportunity, and I'm open to questions if the team has any. Thank you.
All right, I have a question. So who's the buyer of this?
Yeah, that's a great question. So from our perspective, there are a couple of different elements in terms of go-to-market. We're seeing a lot of movement from the payer community in terms of trying to engage patients, and that applies to, I would say, self-insured employers as well. We're also seeing capitated care models are trying to do a lot more to manage that patient population and stratify the risk and really get the patients engaged. So I think there's a variety of potential targets. I would say healthcare systems that are integrated, that have the payer and the provider function as a set. I think payers on their own are also trying to engage their insureds. And then we're also looking a direct-to-consumer approach where there may be a freemium element there as well.
Nirav, thanks for your presentation. Describe a little bit to me and to us how you think this richer interface would look like to enhance the patient-physician relationship as they're looking together at this platform to make clinical decisions together.
Sure. I'm gonna scroll back just to go to that slide, and so we can talk to a little bit. So we think that so fundamentally this is a mobile and web-based solution for both the clinical use as well as for patient-facing and individual-facing use cases. We do have the ability to plumb data in our proposal back into the EMR, but that cannot be the time series data of someone's wearable across the history of time, right? It's got to be the very specific data that matters. So I think from our perspective, the interface for REAMS, this is, for example, a mock-up of a timeline that this is actually a demo from what we have today where we can show prescriptions overlaid with visits. So you have a timeline view, so you can actually see what's been going on with my patient in the context of a particular illness or to manage a particular chronic condition. So this is one view. We have other views where you can actually click on, for example, the office building, and that'll show the data that was relevant for that particular hospital visit. You can click on a particular drug and look at how it's changed over time. And this is a 3-month view. And for example, there's a 1-month view, 6-month view, and 1-year view. And so we see a variety of these views depending on who the consumer of that data is. Okay? And fundamentally to us, it's really about making sure both patient and providers have access to the same data, so it becomes a team approach. Okay.
So, good approach. What I'm interested in is you're getting potentially streams of data that are coming from different sources, like devices and others, and some of them may be duplicated or inconsistent with each other. And so, how do you determine the important data and how do you to the data?
Yeah, so great question, and I'm gonna try not get too deep into the weeds here, but so we have a time series database that is used for kind of this data that's very periodic, from let's just say wearables, remote monitoring. That goes into a time series database, and with all of that data, we have and so on. So we have that provenance stored natively with each data stream, and then as part of the storage of the data into that time series database, we can do a normalization, right? Because some data is being collected once every 30 minutes, some may be on a daily basis. And then the data engines really the noise from the signal, as we would describe it. And so ultimately it's that effort to really cleanse the data through the data engines and drive insights.
I loved your quote, data alone is not interesting, but you need actionable insights. You mentioned analytic engines to drive those insights at the individual and at the care team level.
Sure.
Can you be more specific about what those analytic engines are and what are going to be the first use cases for the types of insights you will derive?
Sure. So in this, the bottom figure here kind of talks about a data engine. So we're using machine learning with TensorFlow and technologies of that like the data and to look at correlation across different streams. And the first use case, and we actually had a video as part of our submission, and that's a hypertension use case that we're looking at because what we found in our research is, a person's receptiveness to prehypertensives can actually vary depending on their genetics. Take their data, I think we can look at medicine in a very, very transformative way. And so it's not only about exchanging the data, but really helping move the bar forward collectively with the community.
Sorry, we're out of time. We have 5. Thank you. I probably should have mentioned that earlier. So because it's sort of like Shark Tank, there's a 5-minute limit on the presentations, and we also allow our judges 5 minutes to ask questions to keep us on time and make it fair for everyone. So our next team to come to the stage, please welcome ML Cardio.
Hi, hi. Good evening, and my name's Steve Pack. I'm here with my colleague, Dr. Danielle Blardo. We're cardiology fellows from Mainline Health System, which is right outside of Philadelphia, and we're here to present our project to implement Bluetooth technology to help outpatient monitoring of our patients at our hospital. So as cardiology fellows, we have the opportunity to care for patients with a variety of different cardiovascular diseases. And as our keynote speaker alluded to, one of the most common problems is hypertension. It's a very challenging metric to monitor. So oftentimes we ask our patients to measure their blood pressure at home. And then they'll bring in a list of blood pressure measurements, and then we'll help them review their medications based off of their blood pressure. But what's wrong with this process the way we have it at our hospital? So what you'll see is, we'll have our patient, and the patient will go home, with their blood pressure monitor, and we'll ask them to write down all these measurements. But the problem is a lot of times they don't remember to do so. And then they have to take the time for a follow-up visit, so they'll drive over to the clinic, and then they'll show us all of this data, which can sometimes be illegible. The doctor's handwriting is illegible also. And then during the visit itself, it takes the doctor time to analyze this data, and then finally the physician will make a decision as to whether or not to adjust the patient's medicines. This process may seem simple, but as I just mentioned, there's a lot of hang-ups that can happen, and many of our patients have a lot of burdens in their life that can make this challenge challenging and add to the difficulties as they already stand. And this can decrease their compliance with measuring their blood pressure, and it can also decrease our ability to help care for them. So this past spring, Mainline Health has been able to install and implement the electronic medical system Epic, which has given us the ability to do a lot of remote patient monitoring. So if we take the same patient and then we give him a fancy Bluetooth blood pressure cuff, he'll be able to take his blood pressure, which can then be synced with his smartphone and then almost instantaneously be uploaded to our database. And then the physician, before the appointment, can review the patient's data, and then more at their leisure or more with their flexible timing, they can decide whether or not they need to make adjustments to the patient's medical regimen. And so what we're hoping is that with the decreased burden of the patient, and the overall increase in care, this will increase patient satisfaction. But on the hospital side, if we have more opportunities to do remote patient monitoring and increase different sources of revenue, and then hopefully prevent unnecessary admissions and prevent readmissions, this will increase the hospital's profits or the health system's profits. So with that, I'm just ending my presentation, and I'll take any questions.
So thank you for your presentation. And the concept, it makes sense and is intuitive. My question would be, though, where is your product fit into this scheme? So I could see the patient having an Epic app that just imports all of this information into Epic. Where is your contribution to the, that life cycle of the?
So our overall contribution would be to implementing it and then analyzing it and trying to optimize it. And then hopefully publishing papers to help other health systems optimize their systems as well.
Thank you.
So are you recommending a specific type of blood pressure device? Do you provide it for the patient? Do you have a list of those that are acceptable, or do you take any that the patient uses?
No, we don't have a list currently. We're currently going to be piloting different types of blood pressure cuffs from different companies. I think, part of the model would be hopefully if we can generate revenue from this type of remote patient monitoring, we'd be able to offer the patient the blood pressure cuff so they wouldn't have to pay for it out of pocket. That would be one idea. Hopefully in time, insurance companies will be able to pay for it because they would see the overall benefit.
So one of the things we hear from overburdened docs is that whatever insights delivered, no matter how great, have to fit within the workflow. They can't be extra clicks since they're already dealing with a clunky EHR. How have you conceptualized this issue?
Well, part of it will have to be obviously weeding out abnormal versus normal data. But we already have this sort of workflow because a lot of the physicians that we work with, I mean, they're already dealing with a lot of data like laboratory values, which come in if you have a large patient practice with thousands of patients, you're getting new laboratory values every day. So I envision this process, an abnormal value will be able to go to the patient's mailbox, and just like they're reviewing laboratory values, they'll be able to see if this is a dangerous value, if this is like just a slightly abnormal value, and they'll be able to call the patient back in an appropriate amount of time.
So how easily can you extend this to other devices? Is it really limited to blood pressure cuffs at the moment?
No, it's you can extend it to a lot of different, not just cardiology. Cardiology would want to measure blood pressure, weights for patients with heart failure. We'd like to extend it to different types of heart rate monitoring to measure normal versus abnormal heart rhythms or heart rates. You know, they're making devices for glucose monitoring for endocrinologists that can help their patients with diabetes or even internists. So it's really the sky's the limit with this type of technology.
So as a certified EHR, your Epic would need to allow you to incorporate information from apps and APIs. So have you considered looking at available apps and which ones your patients might be able to use and as a library that they can choose from to give you data and set up triggers for your clinicians?
Yeah, I mean, there are apps. I guess the model that this will probably work is a lot of these apps will have to be filtered through Apple iHealth, which would then communicate with MyChart. So, I think there's going to be a time, and I'm hoping that we won't have to just pinpoint, one company, but the patient will be able to choose, maybe I like this device versus another device. And so there will be some sort of universality that they'll be able to, upload. It'll probably be funneled through Apple at some point. They're so big.
Great. Thank you very much. All right. Now we have team number 3. Please join me in welcoming to the stage my PHI.
I feel good. I knew that I would not. I feel good.
All right. Thank you very much for this opportunity. We are a physician, a data scientist, and a technology engineer, and we're here to bring you a solution called My PHI. We're trying to knock down barriers to health data sharing by putting full control of health data sharing into the sole patients of the hands of the patient where they rightfully belong. But what are we trying to solve for? Well, I recently met a patient advocate who has lupus. She has had it for 25 years. She sees healthcare professionals in 3 health systems that do not communicate with each other. And therefore, she's ended up with multiple duplicate tests and delays in care for that reason. Well, she's also very apprehensive. Every time she's going to travel out of town, she's concerned because, God forbid, she gets sick. She may end up with the wrong treatment just because she hasn't been able to communicate accurate and complete information to the providers. And on the other hand, the receiving providers are extremely concerned. Lack of accurate information, timely information to help your patients do better. So patients and providers end up very frustrated. And provider-centric approaches to health information exchange haven't worked so well so far. Well, my PHI is about to change that. We're bringing a new approach to health data exchange by putting full control of every single aspect of health data exchange into the hands of the patient. And what we're going to accomplish here is that the patient is going to give us access to their data. We'll collect a longitudinal view of a comprehensive patient data that will be accessible to every single stakeholder, ending up with health systems having the insights they need due to the layering of our health information analytics platform to give them the ability to design personalized care for these patients. In the meantime, frontline providers will cut down on the time it takes to collect data from patients and analyze it. They will have better and faster interventions for these patients. They'll have improvements in their workflows, improvement in their revenues, and hopefully enhancement in their patient care experience. And Yin will tell us how we do that.
Thank you. So this is our solution. At a glance, this looks like any normal my chart, but look closer, it is very different because we're providing you the healthcare indicator for the patient life. So the data is getting updated every day, maybe every hour. And then the my chart, our portal will bring up the issues that you get from the patient and then draw your attention. So our patient Jane is otherwise very healthy, but today suddenly her LDL reading is jumping up, and she is very concerned about that. So this is once she clicked on that link, this brought her to see an upward trend over the years. But just please note that the lab data comes from a few different clinics that would not otherwise communicate with each other. So with this platform, we should be able to bring everything together and show the trend and show the escalated reading from the most recent visit. Of course, this is a very simplified example. She texted her doctor, and her doctor prescribed the medication. Or could happen through the healthcare portal. This is simple because I wanted to bring a point that it is the AI engine behind all of this that bring all of the information to seamlessly download the information and integrate them, normalize them, and then eventually draw clinical insight out of all of this information, and then bring the most important issues to the patient for him to seamlessly share with his physician. One more thing I want to say is the AI engine is where actually we put all the physicians' willpower and brain power, knowledge, and working closely with data scientists or engineers to help them to code out all of the algorithms. That will become our ever-growing brain of those.
So I can explain how the system works. So my PHI has a very simple promise to collect healthcare information from multiple sources, from multiple providers, and from multiple devices. We're planning to do that, and we're doing this right now by just getting the username and password from the patient. And our goal is to make this health information actionable and easy to share with different providers. Currently, we were able to develop generic algorithm to download PHI or personal health information from different healthcare web portals. And on the top of that, we were able to run different analytics. And our goal and our next step is to automate the data collection process by utilizing and deploying our architecture in Google Cloud. I don't really have time to speak about that, but we are planning to utilize those technologies on the next slide.
Great, thank you for the presentation. And judges, any questions?
So I noticed that you had the health indicator on one of your slides, which gives you a quick snapshot of the view of the patient. What goes into that health indicator?
The health indicator actually will try to take all of the outpatient data or the hospital emergency, all of the kind of data together by working by applying an algorithm that we're going to develop with physician. So that probably will kind of perform the risk stratification on the patient to categorize you as low risk or excellent health, good health, fair, or need attention, this kind of stuff. So that's what the health indicator means, whether you need physician's attention right away or not.
So how do you see this being used by a healthy patient?
Well, healthy patients are healthy because they actually do the right thing for themselves. And many patients who have access to multiple health fitness apps would like to have an understanding of how they're doing, how they're progressing in their care and in their own healthy behaviors. So I think healthy patients here would actually have some good positive reinforcement for the good behaviors that they are displaying by gaining access to this combined data. And truly, every time they would deviate from their main usual outcomes, they would certainly have some feedback to bring them back on track. So we want to keep healthy patients healthy by giving them these kinds of insights.
What about the opposite end of the spectrum in terms of engagement? How do you see or how do you think that those that are not healthy and are struggling with doing the patient compliant components of their health, how do you see them engaging?
So in this case, what we're doing here is not only to collect the data, but to integrate it with patient preferences. So we're trying here to make sure that we personalize not only the analysis, but also the output to the patient's needs and to their own preferences. And we're hoping that by addressing patient-specific needs, through these fairly specific algorithms, we'll be able to engage those patients more in their own care, because we do know that giving generic advice to patients do not typically lead to them changing. However, giving them specific advice that address specific needs make them feel like you know them, so you know what you're talking about. So that's the way we'll use it.
So how are you going to render the insights from your analytic engine back to the doc's eyes through the EHR so that they can actually use that information in the context of their workflow?
Flip through a few.
Please go ahead. Back.
Oh, back. Okay, so this is what we see. This is a provider view. We did not get to present in this. So any normal time, if the patient chooses to share his information with the doctor will have the information of all of his patients who shared. So through the algorithm, we should be able to categorize the patient is in health, excellent or good, or need immediate attention. So from here, the doctor, if he is very busy, he will only need to click on the top, who needs immediate attention, and also the patient who might just get discharged from a hospital and still did not have any appointment, so he can click on that to figure out.
So follow up, do they have to get out of their EHR and sign into your system?
Well, we are planning to send HL7 messages to the EMR system. So basically our system has multiple ways to communicate with the hospital EMR. HL7 is one of the ways.
You mentioned patient preferences, but I didn't see where you provide information to patients, but where do they provide their preference and their new goals so that you can adjust and give it to the doctor as well?
I think it's visible in one of the slides that shows that patients can actually enter their own information on the platform. So it's not just about collecting EHR data or wearables or IoT data. It's also about patients being able to manually input data. I believe it's somewhere here. Yes, they can actually manually input their data, and we will use the platform to integrate care plans and develop goals, and patients will be able to modify those goals to adjust their care plans to their own preferences.
I want to make sure that we understand that we are not storing any PHI data on the mobile phones. Whatever it's entered in the mobile phones, it is going in our HIPAA-compliant Google Cloud, hopefully Google Cloud. So we're not storing any PHI on mobile devices. It is just a viewer.
Great, thank you very much. Our next team to present, please welcome Future Assure. Maverick?
Hello, welcome. I'd like to welcome everybody to the danger zone, or should we say, maybe a little risky business there? Well, that's what the operating room is. And now, you may have noticed that the surgeon who was operating was using magnification loops to improve the visualization of the tissues. Yet what you may not realize is that same organ, the eye, performs an eyeball test when you're in clinic, and that is one of the sole determiners of whether or not you undergo an operation. Now, does this matter? Well, let's look at what Dr. Gawande has shown and put it into perspective. Fully 1/3 of patients in the last year of their life will undergo a major surgical procedure. Now, how is Dr. Gawande going to risk assess and counsel his new patient and boss, Warren Buffett? And does it matter? Well, Dr. Gawande would say we need to think differently. We need to identify that we have lived a good life and then determine when we reach a frail state, because we probably don't want to treat a frail patient the same way that we would a normal patient. And again, does it matter? Well, as a surgeon who has studied frailty and surgical outcomes, I can assure you it's vital. If you look at the bottom 10% or the riskiest patients, you will see markedly different outcomes for that patient population when compared to the other 90% of the normal patients. And what does that frail state get you when you undergo an operation? It puts you in a nursing home, it brings you back to the hospital for readmissions, and it markedly increases costs. Now, wouldn't it be nice if we could identify that 1 out of 10 patients, but how are we going to do that in a busy surgical clinic? But we do have some capitalized time with those patients sitting there. Wouldn't it be nice if we could automate this risk assessment process? And that's what our goal at FutureAssure is to automate this risk assessment process utilizing functional metrics both by questionnaire and by physical assessments so that we will be able to routinely investigate this in the clinic. Now, we have the data to show that we can retrospectively prove that the system works. This is the NSQIP database, so in a national surgical database, we've shown this. But more importantly, we have implemented this process in a major healthcare system, assessing nearly 250,000 patients over 2 years' time. But that's great. There are still barriers and opportunities. And one of the little dirty secrets here is the data cost of entry of a simple questionnaire. Our questionnaire being entered or being filled out by patients in a 200-person clinic at our CV clinic in Nebraska would take a half FTE dedicated specialist to enter that data into any database. So what we propose is a patent-pending mobile solution that is given to the patient in the waiting room where they can put in patient-entered data that we have demonstrated is accurate and reliable. During the vitals check-in process, we perform the physical functional metrics, and then real-time, the physician as well as the patient are provided with a risk assessment to be able to start conversations. And we don't stop there. We can actually give this device to a patient prior to their intervention or operation so that we can give them updates and perform structured prehabilitation, and then after the procedure, the patient can receive the device and subsequently track real-time recovery. What have we put together to achieve this outcome? We have a set of academic foundations, biomechanical, biosensing experts, as well as 2 physicians who have taken multiple companies to market. What do we get for patients? Improved outcomes consistent with goals of care. For providers, real-time risk assessment for patients with complex conditions and needs. And lastly, for payers, real-time identification of those high-risk patients to reduce readmissions and to improve the outcomes financially. I'd be happy to answer any questions, and thank you for your attention.
So is the device just a portal to a website where you do the entry, or is it coupled with actual sensors and activities that you're doing there that it collects?
So we have embedded sensors into the device in addition to the cellular platform that we're using, and then subsequently that will basically go to a cloud-based architecture to capture. And with our device, and we're in talks with software developers right now, the potential is to make it very specific so that, say, a company or a hospital system only wants it on their servers, we can make it so it resides on their servers, or do you want us to provide cloud-based platform for you? So modular at this point, that's the concept.
Do you have any plans or roadmap to incorporate some of the data that our keynote speaker talked about? Functional status, patient-reported outcomes, quality of life, and some of the social and economic issues that may be additional barriers to frailty?
That's a great question, and in fact, that's I don't have time to get into all the data that we're collecting, but yes, the goal would be to collect that physical, functional, health, quality of life data. With our biomechanics lab, that's where we have done a lot of work, joining the biomechanical analysis along with quality of life outcomes. So, and obviously, PROs would be part and parcel to this system so that when you are with the instrument at home, we can track whether or not you are having a quality recovery.
So I see the output when I look at your graphs of what happens if you're a high frailty index. Are you recommending that everyone with a high frailty index then has no procedure or alternate procedure, or is there additional recommendations that you can help the physician to advise the patient to decrease that index, for instance?
Yeah. So one of the things with the frailty tool that we use and the physical assessment functions is that each one of those is actionable for the patient prior to the operation. And what we've shown in our studies is that most patients generally do still undergo the proposed operation. It's that we prehabilitate them and then track them very closely in recovery. So at the end of the day, that's sort of the model that we're basing it on. But as far as alternative treatments, there's no question that when that red light goes on to say we need to stop and do a surgical pause, that you would, as the physician, consider other options. But you know, when you're a surgeon and all you are is a hammer, you may not think of those other options.
Two things: who pays for this, and then do they access this report through, you know, a web-based portal, or do you have a way to export the data into an EHR, so some kind of report? Or
So two questions there. First of all, we would consider this a subscription-based model. The beauty is, because it's a portable device, we would be able to, let's say you want to join our program, we send you 10 devices via the mail, and it gets set up, and you just start running it in your clinic. So that's one. And then as far as the output right now, it would be on the device itself along with a web-based viewer. But obviously, we have designed it so that the individual components of the questions and the physical assessment measures would be going into the EMR and flow directly in, because we want to be in front of the EMR. We want to be agnostic to EMR so that all that data can go anywhere, and it would also be able to be on its own.
So on that, to follow up, once you get the devices in the mail, how do you envision training? Who's going to do some of this training that I anticipate at the clinic site?
Yeah.
And how do you ensure reliability and inputs on the device?
So the questionnaires, we have validated studies that show that it can be completed by the patient. And the tools that I showed you, that simple JAMR dynamometer and the iPhone that we measure your walk speed with right now, literally with a stopwatch, all we are doing is combining that into a package. So surprisingly, our MAs at all our clinics are the ones who are doing this, and we really have not had any specific training for them. It's so intuitive for them to incorporate into clinical workflow. It's just an obviousness factor.
Thank you, Tom Cruise. Okay, that was our fourth team. And so we're halfway done. Anyone who's standing in the back, if you want a place to sit, again, we have an overflow room just out the door and on the opposite wall where you can sit down. You're welcome to stand as well. So please welcome our next team, Health Steps.
Hello and welcome. Thank you very much for selecting Health Steps. We're very honored to be here. My name is Benjamin King.
And my name is Brian Tischer.
So what is Health Steps? Health Steps is the evolution of patient engagement, but I'd like to tell you how I started Health Steps. Health Steps was started when my mother was diagnosed with a glioblastoma brain tumor. As she progressed through her treatments, from surgery to radiation to chemotherapy, where she was also enrolled in a clinical trial, the burden of her care shifted to my brothers and I, and we had to manage her care directly. And we thought, we all carry these great smartphones in our pocket. There must be an app for care coordination between family members. And unfortunately, there was not. So I created Health Steps, and my mother was the inspiration for this. Health Steps is a mobile health platform. It is designed around the concept of a digital care plan that can be connected not only with the patient, but to their family members and also to the healthcare providers. Health Steps is your digital care plan on your iPhone or Android mobile device, and it consists of activities such as taking medications daily or weekly, detailed instructions and links to other multimedia resources, and reminders to help you stay compliant with your care plan. Also, you can report and track symptoms in real time, such as pain or fever or nausea, and it can integrate with other wearable or medical IoT devices like capturing blood pressure or weight, or any other consumer devices that can connect to the iPhone. Now, the real heart of the Health Steps platform is the ability to share and synchronize your care plan, like I mentioned, between family members, and most importantly, back to the healthcare provider. Through our secure HIPAA-compliant server running in the cloud, healthcare providers can also create your digital care plan and can easily share or enroll patients by scanning a QR code or sending a secure link to the patient or family member, which is very ideal in the case of pediatrics or for patients that have a surrogate caregiver. Now, the Health Steps web dashboard also provides a real-time analytic dashboard, so you as the healthcare provider or your team can see in real time how compliant patients are with their care plan and also what symptoms they're reporting in real time. We also have the ability to send surveys, and the survey data will show up in the Health Steps web portal. Now, I'm going to turn it over to Brian.
Sure. Thank you, Ben. There are in 2020, there will be 270 million people with smartphones in the US, and just over 86 million of these people will actually own a wearable device. The proliferation of mobile connectivity, coupled with the advances in wearable and biosensing devices, has actually led to enabling a connectivity to patients on an unprecedented scale, kind of creating a new dynamic in the physician-patient relationship, and Health Steps is leading the way. As you can see, our solution is based. Our solution is based on a very simple, forward-looking plan. Enabling those steps that a patient must follow to stay healthy or manage a chronic condition to be available to them in an interactive fashion, right in the palm of their own hands. Preventative medicine recommendations, also disease-specific activities ordered by a physician can be available to that patient, driving the ability for the patient to stay compliant with their care plan and to become healthy. Interoperability between the platform and the EMR allows that physician to see now vital patient-reported outcome data and symptoms and be able to act on that in real time by adjusting the care plan activities remotely. It also allows Health Steps to retrieve information from the EMR and specific data elements, allowing the platform to really predict those next steps that are going to keep that patient on path. Currently, our vision for Health Steps is to allow providers more data points to make medical decisions. It will also enable providers to adjust care plan activities in real time, completion of more robust data sets, and applying predictive analytics and artificial intelligence to really improve that patient's ability to become better. Also, to improve the patient's ability to really have a predictive ability to improve health outcomes for everyone. Sounds fantastic. This is being used right now at UF Health, and the physicians at UF are using this to manage remotely patients with pediatric oncology issues, hemophilia, and sickle cell disease. Thank you for hearing us today, and welcome to Health Steps, the future of patient engagement.
Thanks.
So what is the requirement from the patient? So I just think of I have grandparents who are 92 years old, one who texts me probably 3 times a week and is on every device you can think of, and another who has no idea what any of that means. So what's the burden requirement for the actual patient?
So the Health Steps platform is a mobile application that can have their care plan on it. So they would get reminders to take medication. All they would have to do is check off that they took a medication, and if they want to report a symptom, they can select a symptom from a list, and that's customizable by the healthcare provider. And then once they select a symptom, they could report the value. So for example, pain, you have a scale of 1 to 10. Fever, you have the option of entering the temperature. Nausea, you can report you had nausea or not, or if you threw up as well.
So your mother must be very proud.
Thank you.
That speaks to an incredible need. In the spectrum from assessing the patient to creating a care plan to implementing a care plan and then feeding back, where does this happen? Is the care plan, are you presuming that the care plan is already in the device and you're going from there? It just wasn't clear to me what part of that spectrum you're covering.
So we have a web-based portal, and that's what the healthcare provider would use to create the digital care plan, where they would pick out the activities and/or symptoms that they would want the patient to follow and report, and then they would share that with the patient or the family member.
Thank you.
So to follow up on that question about care plan, many EHRs have a concept of a care plan, and there are standards dealing with care plan, and there are many of them. So are you working through some kind of standard that you could import a care plan and modify it?
Well, most of the care plan features that you see that are a part of the EHRs do not give reminders to take daily medications. They will give you reminders for appointments or for lab results or to refill medications. We are a much more active, and we want to be a more engaging solution so that way you get the reminders for each medication occurrence. And also they do not let you report symptoms as they occur. Our application does let you do that. So we're filling in the missing gaps of where the EHR mobile apps, are where they are lacking features. We have that feature set. And our goal is we want to be able to integrate our data back into the EHR, so when a healthcare provider is reviewing your medical record when you come into the clinic or when you come in for your appointment, we would love to have the Health Steps tab. And that Health Steps tab would have your patient-reported outcome and your patient-reported generated data, so then the physician could see how many times the patient reported pain, or how many times they had trouble sleeping, or if they were actually taking their medications.
So as you're thinking about adoption, are you targeting physician practices or individuals?
So right now, we're actually targeting the clinical trial space. Okay. We want to be the electronic patient-reported outcome and electronic clinical outcome assessment tool for capturing quality data reported by patients and their family members or caregivers. But our long-term plan is to target healthcare providers and insurance companies once the payment model changes for patient engagement and it becomes more appealing.
Thank you.
So there'd be one account for a single patient,
Correct.
but then multiple users. How do you avoid chaos and anarchy in terms of one patient, 10 family members, and do they have access rights to input data, the family members too? I mean, how do you make sense of such a diverse input field?
So right now for version 1, that's correct. You would create the patient in the Health Steps web portal, and then you would be able to share that care plan with multiple family members. And whichever family member checked off that medication or reported a symptom for that patient, you would see which family member did it by name. And right now, with our work at UF Health, we only have moms and dads who are using the care plan for their child. So we're still building out the feature set to support a family of 10 members who might all be helping take care of one patient.
Do you have any embedded behavioral science around self-efficacy, around stages of change, or the patient activation measure? What are your inputs with regards to the determinants of those behaviors?
So we have not gotten that far yet. We started the company just over a year ago, and right now we're doing our first couple of projects with UF Health, and that's something that we would love to do next.
Thank you, judges. Thank you. All right. Moving along to our next team, please welcome Ideal Health.
Thank you. Thank you to our hosts. Thank you to our judges, co-finalists, and thank you to my team. I am truly honored and privileged to be presenting here today. Just for a moment, I would like you to imagine that this is what we used to look like in the past, an engaged audience. And just for a moment, I would like for you to imagine that this is what a provider visit used to look like in the past, when doctors had time to sit with their patients. Now, this is what we look like today. Still an engaged audience, and now active participants with our mobile devices, which have become a vibrant extension of our very own thinking. In fact, how many of you right now are holding your mobile device in your hand? That's okay. We turn to them for everything, our communication, our entertainment, our answers. But here's the problem. Stuck? There we go. This is what a provider visit looks like today. So I'm a doctor from New York City, and I just didn't have the time to think of my patient as an active participant in their care. And so yes, I would approach prevention. I would say such and such will lower your risk for stroke, and that didn't mean anything to my patients. They didn't want to be treated like a textbook patient. They wanted to know how their risk would be affected, whether it would be worth it to make the change, what that would mean for them individually. And I didn't have that information. Imagine, what if it could be a different one day? We could change that. What if health records could be seamlessly integrated? Instead of data being stored in some unused EMR data warehouse, we could upload that to mobile technology. What if patients had personal risk calculators? Instead of being treated like the textbook average patient, they could be actively engaged to get the individual attention they deserve. What if physicians had a better workflow? Instead of technology taking time away from them, we could give it back to them to be with their patients, because some tasks really could be done with the click of a button. What if we had a tool that did all that? Today, Ideal Health. How do we do this? Ideal Health is the first to combine 4 pillars: fully integrated healthcare data, advanced analytic modeling, direct patient engagement, and efficient provider workflow. Ideal Health is embedded in a real HMO, serving 4.5 million members, where EMR data is automatically uploaded into an app-based platform. Thereby, we can actually follow and track our patients using their individual data. And this creates a foundation, but it's only a foundation, because in order to engage patients, in order to save providers time, we have to do something innovative with that platform. We started by creating risk models for major diseases like stroke, using hundreds or even just small pieces of patient data. We show their individual risk, and we compare that risk to their peers. But this, although it makes it real for the patients and it makes it their own, is not actually enough. Okay? There are many predictive models out there, but we do something different. We use a causal inference model, which can actually isolate how modifying that risk factor will affect their total risk. As a result, we can directly engage the patient because they can choose, they can compare what it means to, say, lose 10 pounds or quit smoking and see how that affects their risk profile. Once they do that, now they are actually empowered to make a change. They can see the effect of what that change has on their risk, and they can decide what they have motivation to actually do. Now we're talking about the patient being able to choose a goal on the app, identifying what they prefer to do. For example, quit smoking, because they've already been able to visualize the success that they achieve in their risk. Automatically, the provider can instantly approve supportive measures, like sending a prescription, a referral, a follow-up visit, with literally a click of the button. By doing so, the provider gains control of how they spend time with the patient. What do our users say? They love it. It works. It's like having a doctor without an appointment. It gets into your head. It wakes you up. Somebody finally helped me understand what my risks really are, and I mean to do something about it. Ideal health is based on the ideals of the past. Patients who are engaged, providers who have the time they need, and it builds using innovative technology an ideal provider visit of the future. Integrated data, personalized risk and goals, and ultimately serving patients and providers to achieve success today. Thank you.
You used the term causal inference model. And I'm wondering if we're using that in the statistical term, because I worry a little bit about AI and real-world evidence and causal inference. So my question is, are you claiming too much, and can the technology deliver on real causal inference?
Sure, that's a fantastic and very well-informed question. I think that when we think about the difference between predictive models and causal inference models, really what we're trying to identify is, can we separate out what are going to be sort of mediators along the process? And what we've learned from the models that we have developed is actually we don't need all that much data to do so. In fact, we have models that we can run on hundreds of variables, or we have models that we can run on just a few. And they're frankly very similar. But ultimately, at the end of the day, what you really want to get to is not just a prediction. Having a really accurate 12.3 prediction really means, frankly, nothing to anybody. But being able to compare what that prediction would be if you change just one variable, smoking, not smoking, weight, up, down, actually means a lot to people. And I think at the end of the day, that difference is far more important than the absolute value. I think, yes, actually, we can get pretty close. And I think more importantly, most of the modifiable risk factors speak to people. They know they should stop smoking. They know they should lose weight. But when you make it visual and you make it real, that's when we think that this can come in and really affect change.
So what's the horizon for which you're predicting at? Is it like, your 10-year risk, your 5-year risk, 1-year risk?
So the idea is that we've built a platform that can use any risk. We've chosen a couple of diseases to start with, sort of the major, most costly or most burdensome on the patient. And really those risks should be suited to where the medical community best understands them. If it's generally a 5-year risk or a 10-year risk, that's where they should be directed. Because we're not looking to change how we understand medicine. We're looking to change how we perceive it, and especially how patients engage with it.
Did you say this is being used already by a health plan with 4 million people?
Yes.
So do you have any data collection that shows behavior modification, like outcomes that have been impacted or changed?
Yeah, so we've started with it's being used in the health system. We've started with focus groups, and we've seen already that patients respond to it really positively. They say, "Wow. Yeah, I knew that I was at risk, but wow, this means I'm going to change." And we'll track it. We really believe that this experience of actually physically changing on the mobile app from smoker to not smoker will actively engage them in that process. And that information will be passed on to their clinician so they can have a follow-up visit and they can engage with that decision to choose a goal.
how is this different from current risk calculators like ChadVask or Framingham, in which you can do that already on the web?
Sure. So a couple things. First, doing that already on the web is great, but this automatically brings the data into the calculation, saving some time. More importantly, when you change on Framingham, for example, or ChadVask, smoking status or weight, you're not actually changing whether you lost weight. You're just saying someone else who hasn't smoked up until today, what would their risk be? Okay, it's still an approximate risk prediction, but it doesn't mean that your risk will change because of that action, okay? And this is a subtle distinction, but it makes it very real, because suddenly we're not just saying what someone else's risk might be, but what your risk would be if today you stopped smoking.
Great, thank you very much.
Thank you.
All right. Now our second to last team, please welcome Hype.
Hi, thanks for the opportunity to present. My name is Harish Chandra Butla, and with me is Dr. Anand Bhatia. So what's the Hype all about? Hype is a hypertension predictive patient engagement platform. Hypertension, we've already had a nice introduction from our keynote on hypertension, so I don't need to go into too much detail, but hypertension is characterized by high blood pressure, 140/90 over a series of days or readings, especially with the in concert with the clinician. We see hypertension costing the
hypertension as an example.
costing the
There's any
there's a healthcare cost of over $40 billion, and for each individual patient, we're looking. It's about an average of $1,000 out of pocket for patient per year. So our strategy is a mobile and web platform which allows the patient to manage their own care while also delivering those results to the provider. So it was mentioned earlier, 5 out of 10 people have hypertension. We've seen that it's 4 out of 10. If you include pre-hypertension, this goes up to 6 or 7 out of 10 adults. But 23% of adults are actually in treatment. So that's about a market of 75 million patients. For our platform, we're targeting employee-based programs, and so we're looking at 36 million patients who are in such programs. And so we're targeting from year one 360,000 individuals who may be able to use this platform, and in 5 years get that up to over 900,000. So the hallmarks of our platform are not only are we secure, meeting HIPAA requirements, as I mentioned, we're mobile and web-enabled, but we're really applying AI machine learning to develop a predictive analytics platform. We're using gamification and a rewards program to engage the patient, and we're focusing on medication and management, activity and fitness, as well as critical healthcare outcomes as well. So the predictive platform, we're focused on the patient and provider. We're looking at the entire history of a patient's health record, including visits, labs, medications, and tying that to mobile health data from their wearables, their phone, as well as blood pressure monitors. By studying that data, we are developing features that we believe will be able to enhance behavior engagement. On the provider side, we can provide all that data, but our goal is to really provide a decision support system that will allow physicians to make better decisions in real time with their patients.
All right, so now we get more into the gamification and rewards program. So like we have a Starbucks account, some of us would have, most of us I guess, and the same way how we get star points the second we do an activity. Similarly, in this particular application, you will have certain reward points that will pop up, and that would keep you staying engaged on the app. One of the key features is that we're going to have a video engagement tool where you can actually say how you feel, and at the same time also when you take the pill, you take the pill and you just take a video of it. Now, the idea of that was to create patient accountability. And through accountability, we'll be able to get patient better involved in their own health. And they'll also take quizzes, which would be after watching a video, and that video would be educational for them. Moving on, so as we discussed, there's a certain amount of patient data that comes in from different platforms, and that has to go to a platform from which there's a certain amount of data that goes out to certain to the provider, to the physician, to various other sources. So that is determined from the interoperable platform, and the algorithms will be stored there in the cloud. And the key stakeholders here are the patient and the employer and the provider, around which you have the payers and pharma who will build around it. So we're trying to integrate all the platforms. At the same time, on each patient, an employer can save roughly around $720 per year, and that would be after investing $205. And the roadmap, Harish will walk through.
Well, real quick before we end, we're going to try to launch a pilot program in the fall and launch some apps for everyone to use on iOS and Android. And
Great.
Here's our team.
Thank you. Please, judges.
So how are you calculating the savings on a per patient basis? What's driving that?
Right. So the calculation for the savings per patient is roughly through, as you can see, based on the health tracker that's there, there would be a certain amount of engagement that the patient would have with the application. And based on the application engagement, say, for example, if it's 63%, then based on how engaged you are with the app, you get certain HRA points. HRA spend, which comes in from the employers. And the idea is that we're targeting employers who can put money into the patient's well-being, and that would drive patient behavior.
I'm interested in the gamification, the comment you had about a patient actually taking a video of taking pills. Have you actually tested that to see if people will do it?
So we have used family members and friends as a testing platform, and they were actually saying that if we get some money or some reward out of it, I think that's a big incentive, and especially it going into your HRA account. Firstly, it's tax-free, so you don't pay any taxes on your HRA. And as an employer, that's tax-free for you as well, because you can reimburse it against your costs for your patient's healthcare spend. So that was the whole idea of driving it through the employers.
What's your strategy for which specific employers are you targeting? I mean, there's obviously a wide variety, but
right.
How are you going about understanding which employees would have the largest pool that would be affected by hypertension, and what sort of indicators are you using to find that initial target market?
Thank you for the question. So it's actually something that was very key when we were deciding on this application. We realized that through the recent merger of JP Morgan, Berkshire Hathaway, and Amazon, for the 1 million patient population that they have, that their employees, I think this, if we can develop to a certain level, which could connect end-to-end from your provider to your payer to your pharmacy benefits and everything, I think that is what we were looking at as a first model. Hopefully they find our product enticing enough, but that's the plan, at least.
So continuing with the gamification, I guess specifically around the rewards, can you speak to your thinking and approach around initiation versus sustaining behavior?
Right. So, and for initiating behavior, it's very easy to initiate, and that's absolutely accurate. But to sustain that behavior, the idea is to have those rewards that we can show them on a daily basis. So if you see the platform, there is something that says last week on the health tracker. And last week, the patient was at, say, 59% of what their engagement was. But this week, their engagement went up to 70%, or say 65%. And that difference where they do something and they see that on their phone, and they see that that's going against their points and them getting more money out of it, that will drive sustenance and compliance. Is that, thank you.
And so the audience can't see this, but we have screenshots for what the app would look like. And so
Right.
do you, for some of these, it appears that it would just automatically import the data. So you'd use your iWatch to give your fitness data, and you would have a Bluetooth blood pressure cuff to
Right.
give your, and so there's at least a pseudo-objectivity about it, so that the employer or whoever's incentivizing might have a little more confidence that it's actually being done because you're getting the real data. Is that correct?
Could you just restate?
Yeah, so certainly, connecting directly to devices by Bluetooth can be a validation that it came from that device versus the patient entering the data
It's
manually.
like med compliance would have to be, they say, yes, I took my pill, right?
Yeah, I mean, there's two parts to that. Yeah, one, you can ask the patient, did you take this? And of course, that's self-reported. One of the things we were talking about here is the video, actually taking a video of the individual taking the pill. I mean, that's something that we'll work on developing, but there are other comparable companies that are actually building AI tools that are able to say you took your pill through video. And so that would be where we get real validation. The other side of validation with medication adherence is connecting directly into like their CVS account to at least verify that they got their script. And then the other side is verification through like a video AI tool.
Great, thank you very much. All right, and now we have our final team. Please welcome to the stage, PCH Alliance.
Hello, everybody. I'm Michael Kerwin. I'm the Vice President of Continua. So if you've heard of Continua in the past, it used to be Continua Health Alliance, but at Personal Connected Health Alliance. So what we do is, oops, I'm pushing the wrong button here, is we do medical grade interoperability. This is what Continua is all about. So it's for remote patient monitoring. And so I want to tell you a story about that. So everything we've heard today is about devices, Bluetooth, whatever, behavioral change and all of that. This is the real opportunity to really have an interoperable medical grade platform. A little bit more about Personal Connected Health Alliance. Initially, it was on its own, or Continua was on its own, Continua Health Alliance, and it merged with HIMSS along with Health Summit. You may recognize the Connected Health Conference. We have one later this year, and that's being driven mostly by Personal Connected Health Alliance. But we do thought leadership. We bring in collaborators together for policy and advocacy, as well as standards and interoperability, content and research, and then also convening. So we help people make health and wellness an effortless part of their daily life. So we've been around for about 12 years now, but we went through a change when we went into HIMSS, a period of not real good leadership, and finally in 2016, we really came back with a really good strategy for Personal Connected Health, and that is when we developed Personal Connected Health Alliance. But initially, 12 years ago, we set out to solve a lot of these same problems that we're talking about today that are still here. And I sat in the keynote address with Eric Schmidt of Google, the chairman of Alphabet as well, who said he thought by now we'd have this done. After the HITECH Act and all the meaningful use, that we would have figured this out by now. But he made a challenge for everybody out in the audience, along with Hal Wolf, the new CEO of HIMSS, that we need to solve this in the next 5 years. And so what we have done, and it's been around for a while, it hasn't yet gotten full adoption yet. So this is where I'm here, and I want to talk to you directly about that, especially Google and the AMA. I think if you, for the target BP that was talked about, this will help. And we're involved with AMA as well and AHA also on some of these things. But we brought in diabetes care, heart rate, hypertension, COPD, and then health and fitness as well. So we've standardized all of this for data. This is our architecture. Basically, it's a global standard, so it has strong confidence in global standards through the International Telecommunications Union. So this is the UN-based standards body. And so ITU, we consent our guidelines, the 800-page document, to the ITU every year. I go back to Slovenia, actually, in a couple weeks to meet with them to give our latest version of the guidelines, which include fire, for example. But the way it's set up is they have organized it in what's called the H.10 series. So this is freely available in 6 different languages worldwide today, and our next version will be within a year, also converted to 6 different languages. But it talks about the device, it talks about the service, and then it talks about the health information network. So there's all this standardization, and you see all the different standards. These are open plug-and-play standards that we use. But the device goes into, let's say, a mobile app or a mobile device, over Bluetooth, over USB, over any of these, or any transport, if you will, and then off into either health and fitness to innovate for services and or into an EHR, PHR. And then this is the breadth of what we've actually achieved. So over the last 12 years, we went in, you can't really see this very well, but these are all the blood pressure cuffs, the pulse oximeters, the adherence monitors, peak flow, sleep apnea, I could go on and on and on, et cetera. So there's 26 different protocols that currently represent 40 vital sign sensor data points, right, in devices that could make up hundreds of types of devices that could be in our ecosystem today. And so it's so important because these are the clinical and the IT people, you know, the brilliant people that have come together collectively and helped develop these standards, right? And they continue to expand. This year we're bringing home health environmental ventilator in, if you can imagine that. We're making updates to many of these to ensure that remote patient monitoring works for timestamps and connectivity and all this stuff. We're the ones that fix the Bluetooth devices. So I won't say a whole lot, but through your structured data, we can enable the AI, machine learning, and many other possibilities just to make sure that big data happens. And last but not least, our stuff is free. So we give the test tool out for free, we give the guidelines out for free, and soon we'll be giving commercial-ready code out for free. So thank you.
Thank you.
So it's quite impressive what you built in the last 12 years, but give us a use case of how you'd go about using what you've built and what you've done, and walk us through how that would incorporate use of the Google Cloud and storage, and then to the end user, whoever that might be.
Yeah, so we developed the data piece, right? So for diabetes, for example, as a use case. Continuous glucose monitor, blood glucose, and then also an insulin pump. We have all 3 of those within one of those 16 or 26 that I showed earlier. So we allow, I mean, it's just the data going from one place to another. It's medical grade data, meaning it meets the coding, the syntax, the semantics, all of the necessary things for structured data to work. You don't have to deal with APIs. You don't have to deal with you know, with agreements between different companies or partners. That data is already accepted and understood. It's very clear. It's already recognized in the FDA's Federal Register. We're part of the ONC's ISA, the Interoperability Standards Advisory. So we just make that data possible, and we allow them to innovate in any way they want. So I think the main point that I should make here is probably that for any of those devices that you see out there, if they're Continua compliant, they meet a lot of best practices that aren't in Bluetooth, that aren't in HL7, that aren't in other things for remote patient monitoring. So it's almost a must to have this.
So this requires voluntary adoption from the manufacturers of the devices.
It does.
What's your success been on that? Do you have any sense
So-
of penetration?
Yeah, so we started many years ago, really on the consumer side, really trying to push that. Realized that it was a consumer being, device manufacturers, things like that. They needed the demand to come, right? They needed requirements to be said. And so then we shifted. We went to what we're calling the demand side, which is governments, the ministries of health. And this is an international standard, so we work very closely with them. We're in in population-wise, we're in 3.1 billion, population in many different countries. The problem is while we're in their catalogs like the ISA or the Federal Register, there's no real mandate from the demand side. And so I think we're getting there. We just recently saw Catalonia. I know it's not a big country, but inside of Spain, but 7.1 million population. They mandated Continua for glucose meters. And so there are 8 different companies, 50 million euro contract that went through, and now those companies are coming through and getting certified. The same thing is true in Netherlands, about ready to announce. Austria is about ready to announce mandate. And so getting from the catalog to at least recommended, but then to mandate. That's the hope. And we're gaining progress, but we're a small team, and we're all volunteers, right? So we're trying to get this done. So.
I'm struggling to come up with a question. It sounds like this is a transactional standard, or that's.
It is.
It's infrastructure to make all these other things possible, and I think that what you've accomplished or what you're working on is fantastic. I'm just struggling from the standpoint in this competition here today about the patient. It's not really a patient-facing tool or something a patient engages with. It's something they rely upon for the other technologies to use.
It's trusted data. I think that the patient and the provider would feel better if they knew that, not that they're going to care about Continua compliance or whatever, but if most organizations went along that way and it's free to do so, then why not? And it's just most of the devices out there could probably already pass, but there's some problems. And one of the things brought up about blood pressure custom Bluetooth, if you go to Bluetooth, they don't even, the ones that actually qualify at Bluetooth don't even use the Bluetooth blood pressure profile. They build their own based on the technology or code they can get off the internet. So what we've done is said, no, you need to follow these user requirements, time stamping, everything, all has to be in place. These are the main best practices that you should have in a device. And so we certify that through a conformance program.
Coming from Harvard Business School, I have to almost ask this question, but how did you go about fixing the leadership issues that you had if you were there during that time?
I've been, this is 9 years now. I also worked at Bluetooth SIG, so I was a staff member there as well. So helped drive that organization along with Continua Health Alliance initially. Technical director helped develop these guidelines. I also am the PhD Personal Health Devices Work Group Chair along with Dieter Zong of Chongqing University. But we drive the 11073 standards, those standards you see here, and make certain that we get the standards done and keep find a new roadmap and things like that. So as far as leadership, I think there was a big problem, and I've got a slide that talks about this. I don't have time now, but it's, we went through economic problems. Bluetooth changed from Bluetooth Classic to Bluetooth LE. Also, we switched. We had an IRS problem too, and that.
No, but I'm asking, how did you fix it, or has it been fixed?
Well, so all of that's been fixed with time. We're still on what we call a trough. We see indicators really taking going north. So right now we have better leadership under HIMSS. And this is Hal Wolf, who's driving. He's hired in a new CTIO, Innovation Officer, who's just started, but they've given a commitment to Continua and to PCH Alliance to see it forward. And I think now we have sort of the critical mass that we need to really make it. And we've had these other dominoes fall as far as mandating Continua as well. So,
great, thank you.
Yeah, thank you.
So let's have one final big round of applause for our 8 finalist teams. So first, before we proceed to our next speaker, I just wanted to make a quick sort of clarification. Some of our teams who presented today, the finalist teams, focused on hypertension, and it was purely by coincidence that our keynote speaker also focused on hypertension. That clearly will not affect the voting or the judging or anything. It just happened to be a coincidence. Obviously, all the teams will be judged on the merits of their presentations. So while we compile the judge scores, and keep in mind, there's not going to be a deliberation, so it's not going to be a long process. But during that time, we would like to invite to the stage from the AMA, Laurie McGraw, the Senior Vice President, Health Solutions Group at the AMA.
Thanks, Jim. I can't wait to see what happens. I spent the entire week preparing for this event, and which meant that I was binge watching Shark Tank all week, and I'm trying to figure out from our esteemed judge panel who is Mark Cuban, who is Mr. Wonderful. But I really appreciated all of the 8 finalists and just really excellent areas of display of innovation, interoperability, which is what this challenge is all about. A couple things I did want to comment on while we are waiting eagerly for the results of this competition. You know, for the AMA, this is the first time that we've actually done a challenge like this. And as Dr. Hodgkins opened up his remarks, he was talking, I was really glad to see in the audience we had so many physicians. And certainly with the Integrated Health Model Initiative, which Dr. Hodgkins talked about, while it is invited, we invite everyone to participate, not just physicians, but informaticists, entrepreneurs, engineers. The reason for doing this challenge was really for the AMA to start to interact with aspiring innovative technology companies to use and work with us on this common data model to solve a really big challenge in healthcare, which is the organization of well-organized clinical data. We do invite you to join the platform, work with us. It is open to everyone, and we would look forward to having the talent in this room. Dr. Hodgkins also, when he asked for the show of hands, I was pleased to see the number of physician hands that went up. We invite you to be members of the AMA. Your membership moves medicine, and the AMA does a lot of work in the area of innovation. In terms of that, one of the things that we do is we spend a lot of time studying physicians' appetite for innovation and what is important to them. It was really great to hear from the contestants up here that some of the things that physicians care about the most when it comes to digital health, innovative technologies, that the organizations up here were talking about those things. What physicians tend to care about, as we've researched it, include things like, does it work? And we saw a lot of evidence and results that actually showed that these solutions work. That was really terrific to hear, to see. Physicians care a lot about, do I get paid? Will I get sued? That's not just a medical malpractice issue. That's also a program integrity type of issue. And then another thing that physicians care about a lot, and you heard it from the judges' questions, is how do I integrate this into my practice? And there were a lot of, I thought, really excellent answers and thoughtful work from the organizations up here of how the workflow with these innovative solutions and how they interoperate with electronic health records and other tools inside the four walls of the healthcare system, that there was thought put to that so it doesn't become just one more burdensome thing for physicians, clinicians, and other stakeholders to use. The other thing, just for the AMA, we think a lot about the clinician's voice in the development of innovative technology. It was really great to see the number of physicians and other types of clinical providers who were involved in these different organizations up here. So kudos to all of you for that. We think that's wonderful. We think it's needed. We think it it makes for better solutions in the healthcare ecosystem. And we need a lot of innovation. So from my perspective, I just really want to say my sincere thank you to both all of our contestants who were just absolutely phenomenal. To our judges, we really appreciate your involvement as an esteemed collection of judges, really great questions. And this audience, of innovators, entrepreneurs, we appreciate the opportunity to interact with you. So thank you very much.
We're ready.
Do we have our results?
We have them. All right. So I will announce the winners in order of third place, second place, first place. And then I think we have all of our awards to present. Okay, are we ready, Abby? All right, great. So coming in third place, big round of applause for Future Assure. Thank you. Great. Okay. In second place, another big round of applause for Ideal Health. Thank you. All right, and now the moment you've all been waiting for. Of our 38 original submissions online, 8 finalist presentations, it comes down to this one team in first place. Please, big round of applause for Health Steps. Congratulations. Great job. All right. All I have left on my notes is time to go home. But you don't have to go home. We've reopened the bar. There's desserts, and you're welcome to stick around for another half hour or so and network and enjoy the Google hospitality. Thank you all for coming tonight.